Thank you so much.
Hello, everyone. Can you all hear me?
I
So
can hear you.
thank
I can
you
hear
for
you for
joining.
myself.
Thanks, Professor Reham. So hello, everyone. Thank you for joining us this evening. So welcome to this session of the SIOP Africa Education and Training Committee Program. I'm Dr. Ndeifa Tusso. I'm a pediatric oncologist from Senegal and teaching assistant of pediatrics at the Cheikh Anta Diop University of Dakar. So it's an honor this afternoon to moderate this fourth session of the basics modules. So the lectures are recorded and the links will be shared on the SIOP Africa YouTube channel. Please all register with the registration forms link that has been sent in the chat box because 80% attendance makes you eligible to get a certificate. So the lectures are held every Wednesday. So the next one will be on February 5th. If you have any question, you can write them in the chat box. And if we're ready, I think we can start our session of this evening. So the lecture gathering us today is titled Fundamentals of Flow Cytometry. It will be presented by Professor Reham Hammad. Professor Reham is a professor of clinical pathology. She's the head of flow cytometry laboratory at Al Azhar University in Egypt. Professor Reham, if you're ready, you may proceed.
Thank you so much. Thank you so much, dear, and thank you for the organizing committee. It has been a pleasure joining you today. Actually, the sessions of the flow cytometry is going to be divided into two sessions. This one is going to be the fundamental one, and the second one we will dive into the acute leukemia and the panels of diagnosis of acute leukemia and the minimal residual disease. Today, we will start with the basics of the flow cytometry and the fundamentals so that we can guide the journey. We will start by the objective learning, intended learning objectives of this lecture. Well, I do expect, inshallah, after the end of this lecture, that the attendee will be able to understand the fundamentals of the flow cytometry, and they can describe the mechanism of its action, analyze and interpret the data coming from it, also to explain its uses in the clinical setting. Definitely, one session is not going to be enough, but we are going to tackle the important issues and to discuss the limitations of the flow cytometry. Is it enough to depend on the flow cytometry, or does the molecular people have their importance too? And I think they are so important in this setting. Then lastly, what are the recent advancements in the uses of flow cytometry? Once again, thank you, the organizing committee, for having me today, and I hope it will be a simple and easy lecture. I know the flow cytometry is one of the most needed applications now in the era of the oncology, and not only the oncology, and maybe, inshallah, we can do something about it today. Let's start with understanding the basics of flow cytometry. What is the flow cytometry? What do you expect from understanding the word of the flow cytometry? Well, I like this picture so much because actually it explains the whole facts of the flow cytometry. As you can see, what we call it flow means that there's some kind of motion. Cyto, that I'm dealing with a cell, and this is true, I am dealing with a cell, and this cell is actually swimming inside a fluid as even if it is taking a path. Also, there is a light directed to this cell, and this light leads to scattering of the light after it hits this molecule of this cell, and then this scattered light is going to be captured and analyzed by a metry, and this is the meaning of a metry. So, making the long story short, you are dealing with a cell which is swimming inside sheath fluid, something that looks like a saline, and it intersects with light, and this light has to be laser, and we will know why it has to be laser. And then when it scatters the light, this light is going to be turn it into electricity, and then it is going to be analyzed, giving some more information about the parameters of the cell regarding the size of the cell, the granularity of the cell, and also if it carries antigenic structure on it or not. So defining the immune phenotyping as a simple definition, it's a process by which the antibodies are used to identify cells based on the types of antigens or markers on the surface. So saying that, you will have to understand that dealing with the flow cytometry is actually dealing with the antigenic structure on the surface and in the cytoplasm and in the nucleus of the cell. Without knowing what you are looking for, you are going nowhere. So the simplified idea of its mechanism of action is going to be knowing first that the antibodies are artificially conjugated with fluorochromes. This is the idea of the process, that the antibodies are artificially conjugated with fluorochromes. Then, if the antibody recognizes a specific antigenic structure on the surface of the cell, it is going to be attached to this cell. But if there is no antigen to be recognized, there will be no attachment. And so when you are going to wash the cell, it is going to be washed away and it will not attach to the cell itself. If the cell which is attached to the antibody with the fluorochrome, or if I may be more accurate, if the cell with the antigen that you are looking for is attached to the monoclonal antibody, which is conjugated with the specific dye, is going to be intersecting with a laser. This is going to emit light in a specific scattering maneuver, which is going to be analyzed. And this will give you an idea about the parameters of this cell. Each single cell passes alone, and yes, each single cell can be examined alone. Since definitely those are lacking, the markers will not manifest any kind of fluorescence. So we said that there is an antibody, that it is attached to a fluorochrome, and we need now to understand what is the fluorochrome. Let's just say that the fluorochrome are certain dyes. Those have the ability to absorb the light of a laser when it intersects with it, and then it is going to emit light with a specific condition, that this emitted light will be on a longer wavelength than the absorbing or the stimulating light. So many dyes are actually found. One of the most famous that we use usually, and definitely you are aware of it, is the fluorescein molecule or fluorochrome, which we call it FITC. That it is stimulated by a blue laser that is 488 nanometers wavelengths, and when it is stimulated with the 488 nanometers wavelengths, it's going to emit light at 530 nanometers wavelengths. So you can see definitely that the emitted light is emitted on a longer wavelength than the incident light which is stimulated it. This is as simple as that. I have given an example, which is the fluorescein molecule, but this is not all. Sometimes we do have many conjugates inside the very single sample to see more than one antigenic structure on the cell in the very same setting, and we put them all in the same tube. So there is the FITC, the PE, the PERCB, the ABC. So how do I know which suitable fluorochrome is to be conjugated with the antibody so that I can identify a specific antigen? Is there a rule for that? So you can tell me in the chat, do you think that there is a rule controlling that? Do you think that there is a rule controlling the fluorochrome that I choose to the antigenic structure which is found whether on the surface of the cell or inside the cell or intranuclear, so that I can define the cell? Do you think that there is?
Yes, there is a rule.
I would say yes, there is. Yes, definitely there is. There is a very simple rule which actually controls this, which is called the staining index of the stain, which you can identify it as the power of the stain and the antigenic density of the antigen on the surface or in the cytoplasm of the cell. There is one simple rule saying that the staining index or the power of the stain is not the same. For instance, PE has a more is more powerful as a dye than the APC. The APC is more than the PITC, and the PITC is more than the PERCB. All of those are names of dyes that we use very commonly inside the flow cytometry lab. So knowing that, you can now understand that the stronger the antigen is going to be expressed, the dimmer the fluorochrome I am going to conjugate it with, because actually I don't need it to be so powerful. If I have a very high intensity stain and a very highly expressed antigen on the surface of the cell, this will lead to a lot of noise that I do not need. So a very simple conjugation rule in order to pair the antigen with the fluorochrome is what is the density of your antigen on the surface of your cell, and if it is too much or highly expressed, now you can use a dim fluorochrome to pair it with it, and then you will have a very good expression of the light scattered from it. The intensity of the light is not going to be low due to the antigenic density found on the surface. So this very, very simple rule is very important when you are dealing inside the lab to see whatever antigen that you are going to look for. Definitely, rule number 2, you have to know the instrument that you are going to work with, because not all the fluorochromes are compatible with all the instruments. So you have to know your instrument, and then you can choose the fluorochrome that we have talked about. Definitely, many more rules are actually controlling this process, but I know that many of you are actually oncologists and you are not so much inside the laboratory work, so I'm getting the simplest form that I can. Then let's start to describe the flow cytometry methodology in itself. As anything, you can expect that there is a process of sample preparation in the very first beginning, in which there is incubation of the dye that I have added into, that is attached to the monoclonal antibody that I have added to the sample, and then I will incubate it for a specific time. After this, and when I get sure that the stain has already come, I will identify what type of cell that I am dealing with, as we are in the set of leukemia, and most of the cells we are talking about is going to be the myeloid and the lymphoid precursors, and we don't tackle so much the RBCs and the platelet. Then I will lyse the RBCs and the platelet, get rid of them to make sure that I am only getting on the cells that I want, in my case, which is the myeloid and the lymphoid series. And then it is going to be acquired to the flow cytometry, and I will analyze the data. So what is the flow cytometry component that I am going to use for such a mission? Simply as that, and in order not to make things so hard, we will have to understand that the components starts with a light source, and this is the parent of everything and the father of everything that we are saying. That you have to understand the laser you are talking, you are dealing with inside your instrument. The laser is actually the excitation source, which is going to excite the fluorochrome that is attached to the antibody, and will stimulate it to emit the light that you are going to wait and from which you are going to see parameters of the cells. What are the types of the laser that you are going to deal with? Many, if I can kindly ask you to mute yourself, please. Dr. Ziad, if you can kindly mute yourself, please, doctor. Thank you. The types of the laser that you are dealing with depends on the type of instrument that you are dealing with. The most common and the most important of them all is the blue laser. It is the most common. And I will ask you, please, 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 to remember with me its wavelength, which is 488 nanometers. And within 5 minutes, you will know why I have asked you to revise this wavelength. Then there are other types of lasers, the ultraviolet, the violet, the red, and the yellow and the green, and each one of them has its specific wavelengths. Still, I will remind you once again to remember the blue laser, which is found in most of the instruments, and its wavelength is 488 nanometers. It is responsible for stimulation of the most basic things that we use inside the lab. The second question is, I have said that we are using laser, so why laser? Why specifically laser? Why can't I use any kind of other light source? Laser has two specific characters that we need to put in mind. It is monochromatic, it has a specific wavelength, and it is unidirectional. So if you are going to open the source of the light, it is going to move in one single direction unless it meets an obstacle. And in our case, this obstacle is going to be the cell that we want to examine. So usually we use the laser because it has two components of characteristics. It is monochromatic, it has a specific wavelength, so I can stimulate a specific type of fluorophore, and I know
Hello,
that it is
everybody.
going
Good
to
evening.
emit its light in a
You hear me?
longer wavelength. And
Yes, Dr.
unidirectional, so it moves in one
Okay,
single
so can I
direction,
start now or
and it
wait
never
for another few
scatters
minutes?
unless it meets a
I
single
think we can wait
molecule.
just a couple of minutes
The flow
because
cytometry
the
contains
numbers are
some
increasing.
probabilities. The most
Okay,
important that I want you
so we are ready. If you
to
are
know
okay,
with me
just let
that
me know
we
and we'll
work with
start,
something
inshallah.
which is called hydrodynamic
Okay.
focusing. I don't care about you knowing the name, but I care about you revising this figure. Before, the hydrodynamic focusing means that each cell is going to intersect with the laser singly, and it will meet it alone. So even inside the sample, there will be many cells inside the sample. When they are introduced inside the instrument with the laser, every cell is going to intersect with the laser by its own, which gives you a wonderful chance to examine each cell specifically. So when you are looking for apparency or you are looking for abnormal cells, which swings between 10,000 cells, you can define it, and you can define it very simply and very easily. So this is called the hydrodynamic focusing. People who are coming outside the clinical pathology and the laboratory work, they are not actually going to address this so much.
Hello,
but
everyone.
just get
Thank
the
you for
idea
joining
that
us
every
today.
cell
Welcome to
is
the
going
SIPE
to be
Africa
examined
Education and
solely
Training Committee
and
program.
singly.
It's our fifth session
Then comes
the
the most
basics
important
module.
thing inside the
Please all don't
cytometry,
forget to
which
fill
is
the registration
optics.
form.
So we have
Every
finished
lecture, it will
the
be sent
laser,
in
which
the
is
chat
the
box
source of
as
light
if your
that is
attendance is required to get your
monochromatic and
certificate.
unidirectional.
Lectures are held
And we
every
have
Wednesday,
finished
so the next one will be on the
and
12th
we
of
have
February.
refined one
Please don't
single
hesitate
word
to
that
write
it
your
is
questions in the chat
working
box
with
or raise your hands if
hydrodynamic
you want to ask.
focusing, and every
Our
cell
lecture
is
today
going
is
to
about
be
the specific
introduced
anti-cancer
to the laser
immunotherapies and
by
monoclonal
its
antibodies.
to be
It will be
examined
presented by
singly
Professor
and so
Dr.
on.
Yasser Al-Borai. Dr. Yasser is a
Now, let's
professor of
come
pediatric
to
oncology
the
and
most
stem
complicated
cell
part,
transplant
which is the optics. I promise you, it's not going
National
to be
Cancer
that kind of complicated
Institute,
after we
Egypt,
actually
and
examine, after
Medical
we
City, Saudi
take
Arabia.
notes
Dr. Yasser, if you're ready,
on
we
this
can start.
figure, because actually this figure is
Yasser?
saying the
Yeah.
whole process
I'm
in a
here.
very, very
So hello
summarized
everybody.
way.
Thank you so
Let's
much
remember that we do
for
have
this
a
educational
source of light that
program
is
for the
the
South
laser.
Africa.
And this laser
In the
is
next few
going
minutes, we'll talk about specific
on
anti-cancer immune
monodirectional,
therapy and monoclonal
is
antibodies.
going unidirectional
Okay, so
and
first of all, we need
monochromatic.
to
You
know
know the wavelengths and you know
how
its
can we
direction. As you
do
opened it from
fight
here,
cancer
so
cell.
you do
So we have many modalities
estimate
to
that
treat
each
the cancer
kind
cell.
of
Maybe with
direction
surgery,
is
maybe
going
with
to be
chemotherapy,
coming from the laser source
maybe with
to the
radiotherapy,
cell. It's going to be
hormonal
directed like
therapy,
this. You see
transplant
the arrow,
therapy,
is it
target
apparent? It's going
therapy,
to be directed like this.
hyperthermia, and
So
finally,
it will
immune
meet the
therapy.
cell. Can
So
you please
what is
tell
the
me
immune
what
therapy?
happens?
So as you know,
What the
after
rays
many years
coming
of
from the
using
cell
the
after
traditional
the laser
chemotherapy with a lot of
intersected with
toxicities, a lot of side
do you know
effects,
what that rays
a lot of morbidities due to
mean?
the toxicity
What
of the
are those
chemotherapy,
rays? Can you figure
it
out?
was a
You
time
can
to
write
think
down in
about
the
how
chat.
can we use the natural immune system to
What are
fight with
those
us against cancer
rays
away from the
after
traditional
intersection
chemotherapy.
with the cell?
So the immune therapy is a biological therapy that
Do you
help
have
our
an
immune
idea?
system to
Anything.
fight the cancer. So this is a fight between the immune system and the cancer cell. The immune system tries to hit the cancer cell, and on the opposite side, as a defense mechanism, we can find the cancer cell try to find different defense mechanism to escape from this immune system.
Right?
Maybe
Right,
by
right.
genetic
This is
changes
the
that make the
scattering of
cancer
light
cell
after
less
it
visible to the
intersects
immune
with the
system.
cell. This is actually what
Maybe by
happens.
creating a
Now
specific
you see
proteins
that it
on the
has
surface
been
to
moving
turn
in
off
one
the immune
direction,
system,
then
or
it is
maybe
scattered light
by
after
changing
it
the
met an
surrounding
obstacle.
media
In our
around the
case,
cancer
it
cell
is going to be
to
the cell.
escape
This
the mechanism
scattered
of the
light
immune system.
is going to be collected once again.
So
Now
the
it is
immune therapy,
collected
it is not
with a
only
collecting
one type of
lens,
therapy.
and it is
The
going
immune
to be
therapy,
directed
simply
to
we can
something
define
which
the
is
immune
called
therapy into
dichroic
major
mirror.
5
I like
different
to name it the beam
types.
separator.
So
Why do I
checkpoint
name it the beam
inhibitors is a type
separator?
of the immune
Because
therapy.
as you can see, it is
T-cell transfer
situated
therapy
on
or CAR T-cell
45
is
degrees
another type of
from
the
the
immune
light
therapy.
that is
Monoclonal antibodies is
collected
another
by
type
the
of the immune
collective
therapy.
lens.
There is a specific
Half of
vaccine
this lens
targeting the cancer
is
cell, which is
going
called
to
the treatment
reflect
vaccine, is another
the
type of the
light
immune
with
therapy.
specific wavelengths,
And
and
finally,
it
there is
will
another
allow
medications.
by the
This
other
medication
half
has
this light
a
to
primary
pass
action,
through. So
which
it
is
actually
totally away
works
from
both
our
sides.
target,
It works
but
like
also it
a
has a
reflector
secondary
to a
action,
specific
which is
wavelength,
enhancing the effect of the immune
directing it to a
therapy against
specific
the cancer cell. That's why
filter
it's
and
called
a specific
immune system
multiplier tube.
modulator.
Then it
So
will
in the next
allow
couple of
the
slides,
other
we'll talk
wavelengths to
specifically
pass
about
through.
each type of
Let's
the immune
see from
therapy
another point
in
of view.
few
Now you can see
couple of
that the collected
slides.
light is formed of blue light, green light,
So as we
yellow light,
mentioned, we have
and red
major
light. When it passes
5
through
different
the
types of the
dichroic
immune
mirror,
therapy.
the first
Now we'll talk
dichroic
about
and the
the
third beam
immune
separator, you will
checkpoint
see that
inhibitors.
the blue is
So
going to be
in a very
reflected,
simple way,
while the first
what is the checkpoint inhibitors?
dichroic
Normally,
mirror
the
allows
checkpoint
the
like
green,
a
the
brake of the
yellow,
car.
and the red to pass.
So normally
And
the
then,
car is the immune
when it
system
passes to the second one,
going
it
very
allows
fast
the
to
green
attack
light
the
to be
cancer cell.
reflected and
And as a
allows
defense
the yellow
mechanism,
and the red to
the cancer
pass
cell
through.
has
And
an
then when
arm.
it passes to the
This
third,
arm
it
can touch
allows
the brake of
only
the
the
car
yellow light
to
to
make it
pass
slow
and the
down.
red to pass
So
through.
this is the
And
mechanism,
then till we
the
finish
defense
all the
mechanism of
light
the
that
cancer
we
cell
have.
against the immune system.
Where is
So
this
this is
light
the checkpoint.
redirected?
So
It
the
is
checkpoint
redirected
like
to
the
a
brake of the car.
photomultiplier tube.
So the
This
car or the immune system
photomultiplier
had a
tube
brake,
is
and the
responsible
and the
for a
tumor
very
cells
small
the arm
it
that touch the
allows
brake
the
make the
photons
immune
of the
system
light
or make
to
the
be
car very slow.
translated to
That's why
electricity.
the cancer cell
So the
escape from the
journey
immune
of the
system.
light
So
now
what
is
about if I
finished.
inhibit it?
I have been
If I
dealing with
inhibit
light
this
all
brake,
of
I
this
prevented the
time
arm of the tumor
that
cells
passed.
to
Now
reach
I
the
am
brake of the
dealing
car.
with electricity
So if there is
with
no
a
brake,
specific voltage.
there is no
This is going to be
slowdown
assigned
of the
to a
car.
graph
So the
in
immune system or the car
representation
will
of
go
a
very
dot
fast
according
to
to the
hit
intensity
the
of
cancer
the
cell.
voltage.
So this is the
So
idea of the checkpoint
making
inhibitors.
the very
So
long
we are
story
inhibiting
short, we have light which is
the
scattered
brake of
only
the
when
car
it
or
met
the brake of
a
the immune
cell.
system.
This scattered
If
light
there is
is
no
going to be
brake,
collected.
the
It is
car
going to
or
pass
the immune
through
system
ultraviolet
will
mirror
go very
to
fast
reflect a
without
specific
any slowdown
wavelength to a
and will hit the
photomultiplier
tumor
tube
cells.
that it is going to
So
transmit
here
the
we can find
photons
the
of
tumor
this light
cells,
into
and this is the arm of the tumor
electricity
cells.
with a
And this is the
specific
immune cells,
voltage
which is a T
that
cell, and
pairs
this is the
with the
brake of the
intensity
T
of the
cells.
number of
So if the
photons
arm of
which
the tumor
hits
cell
it.
touch the brake of the T cell,
So actually,
so the
what
T
we
cell
are
will
dealing
slow
with
down
inside the flow
and
cytometry
it will not
is
affect
the
the tumor cell.
problem or
But
the
if I
trick of the
cover
light
this part
from being a light
or I
coming
cover
from
this
the
part,
source of a laser
so
to
there is no touch of the brake of
electricity,
the car,
and this
there is no
electricity is
slowdown,
going to
the
be
tumor cell will
assigned
go
to a
very
graph
fast to destroy
according
the
to
tumor
its
cell.
intensity.
So this is the
Making the
inhibitor.
very
So the inhibitor maybe
long
cover
story
the
short,
arm, which is
these photons, after
anti-BDL1,
they will
or
hit
maybe
the
cover the brake
photomultiplier
of the
tube,
T cell, which is
proportional electronic
anti-BD1.
signals are going
So
to be
either
produced. Pulses
anti-BDL1
are
or
assigned to channels on the
anti-BD1.
dot plot
So there is
according
no
to
brake
their
of the car,
intensity.
there is no slowdown. The
Then
T
they
cell
are
or
going
the
to be
immune system
translated by
will
the
go very
computer.
fast to destroy
So the
the tumor
last
cell.
part of
So
the
this
flow
is in a very
cytometry is
simple
going to
way
be the computer,
how
which is
can
going to
the checkpoint
assign
inhibitors
the
work.
voltage according to
So
its
now we have many
the
different
voltage
applications of the checkpoint inhibitors,
according to
either for the
its
solid tumors
digital
or
value
for
to a
leukemia or
specific
lymphoma.
space on the
So
graph.
regarding the brain
And this
tumors,
is
there is
going
a
to be
clinical
so
trial, which
easy
is a phase
when we
2
see
clinical trial of using
the coming
pembrolizumab
slide.
for relapsed
But
or refractory
definitely
high-grade
now
glioma
you
or
will
DIBG or
know that
hypermutated brain
what we
tumors,
are dealing
ependymoma or
with
metроblastoma,
inside this
who
process is
recover
actually
from the prior therapy. But till now,
photons
there
coming
is
from a
no
laser
definite
is going to hit
result
a
regarding this clinical
photomultiplier
trial.
tube. This photomultiplier tube is going
Also
to
using
translate
checkpoint
these photons
inhibitors
to
against
electricity, and
neuroblastoma,
this
there is a phase 1
electricity
and
is
phase 2
going to be
clinical trials
translated
of
by the
combined
computer. If you want a more
ipilimumab and
complicated
nivolumab
name to
for
this
treatment of
part of
relapsed
the computer
refractory
is possible.
sarcoma
For
in
that,
general,
it's called
and this study
analog
include
to
also
digital
neuroblastoma,
converter. Or
and
what
there
we
is
say
only
about the
2
ADC
partial
is going to
response
be translated
were
to
achieved among 55
specific
patients for this clinical trial. This is regarding
space
using
on
checkpoint
a graph
inhibitors for
according to
neuroblastoma.
its assigned part.
Regarding the Wilms tumor, still there is no any result for this phase 2 clinical trial for the Wilms tumor using nivolumab or ipilimumab.
This is the summarization of what we have
Regarding
already
sarcoma,
been knowing
or
from the start.
specifically for
The cells are
osteosarcoma,
actually
there is a clinical
conjugated to a
phase 2 clinical
monoclonal
trial
antibody
using
attached to each
avelumab as
chromosome. The cells are
anti-BDL1
integrated with the
in
laser,
adolescent
and the
with
light is
recurrent
going to
progressive
scatter after
osteosarcoma.
this meeting.
But till
The
now, there is
photons
no
are
demonstrated
going to be
activity
emitting
for
light
this
on longer
study regarding
wavelengths
the
of
effect
the
of the
laser. The
osteosarcoma.
dichroic mirrors are going to separate the collected light,
So, as we
and the
mentioned before,
filters
the
are
major
going
of
to
the
allow
checkpoint
the
inhibitors
photons to travel
against
through
the solid
photomultiplier
tumor,
tubes,
either brain
which is
tumor,
responsible for
neuroblastoma, different
translating
sarcoma,
this light to
osteosarcoma.
electricity.
Till now, there is no
So now we
solid
have seen
response
that we know the
for these
components
checkpoint
of the flow
inhibitors.
cytometry,
But
and its
regarding the
methodology. And I
leukemia and
don't think
lymphoma, there is a little bit
the
improving
process
or
stops at
maybe
here.
a
So
promising
what do you
results.
think is coming later?
So
What is coming later is
using
knowing a
pembrolizumab
depth, a
in
different
AML
scattering phenomena
post-transplant
of the
in
light.
experimental
Usually
arm,
the light, when
including
it meets
9
an
AML
obstacle,
patients
it's either
versus
when
18
it meets a bound,
control
it's either
patient, we found that
diffracted or refracted or reflected
100%
or
survival
absorbed.
at
Those are the
100-day
4
post-transplant
types.
in the
And
experimental arm
you can see
or
inside
experimental
the
group
image the
using
types of light that you
pembrolizumab
are dealing with,
versus 83%
with
for the
scattering of
control
light
arm
you are dealing
not
with
using
after hitting
pembrolizumab.
any
So checkpoint inhibitors in
molecule,
AML
you can see
post-transplant,
that it is
it show a little bit
reflected
promising results.
going to this another
Also regarding lymphoma,
another direction,
pembrolizumab was
or
FDA
refracted, it
approved
will pass
for
through
relapsed refractory
all of these
Hodgkin lymphoma for
diffracted.
adult and
It
pediatric
will
in March
bend after it
2017.
meets the surface,
So it is
or absorb it to
around
be
15 patients with
attenuated
relapsed
by the
refractory
oxygen
Hodgkin
as it
lymphoma
absorbs
were
some of
included in the
its energy.
international study, and
What
60%
we are
achieving
dealing with
response
inside
with
the
pembrolizumab as a monotherapy.
the flow
So
cytometry
this is
is
the first
actually
part of the
scattering
immune
of
therapy,
light
which is the
by
checkpoint inhibitors.
diffraction. What is the
Checkpoint
diffraction?
inhibitors,
The
we inhibit
diffraction
the
is
break
the
of the ACAR,
bending of
we
light
inhibit
after it meets
to make
the
it
oxygen. So what does this
very
mean?
fast
Why
directed
would
against the
I
tumor
care to
cells.
say those
The
details
effect
for
of the
you,
checkpoint inhibitors for the
as
solid
you are
tumors
dealing with
still
oncology
under
and you are
clinical
dealing
trials.
with the diagnosis
Regarding lymphoma
of
and
the cell
leukemia, there is
inside
sometimes
the
of
implant. Actually, this is
checkpoint
very
inhibitors
important
FDA
because
approved, and
knowing
there
the
is a
process,
promising
you
results.
can understand
So
the
this is
whole
regarding
thing you
the
are dealing
first
with the
section of the
instrument
immune
and the
therapy,
whole
which
thing you
is
are dealing
the
with the
checkpoint
diagnosis.
inhibitors.
Let me first remind you
So
about
what
the
about
few
the
lasers
second
that we
type
have
of the immune
taken
therapy,
in the
which is
very
the T
first
cell
part of
transfer
this
therapy,
lecture.
or
Do you
as we know,
remember
it
the
is a CAR T
wavelength
cell.
that we have talked about?
So the CAR T cell,
Of the
simply,
blue
we
laser?
are
Do you
taking the
remember
T cells
the wavelengths
outside the
that
body of
we
the patients. We are genetically engineered
talked
specific
about
receptor.
in
We put this
the start
receptor
of this
on the
lecture,
surface
and
of
we
the T
said that
cell,
the blue laser is the most
multiplying the T
important, and
cells
it is the one that we
to
are
be
going
many millions
to
and
revise and
thousands,
remember its
and to be reinfused
wavelengths. Do you
again.
remember the
And
wavelengths?
these genetically engineered receptors on the surface of the T cell has a specific
Anyone?
affinity regarding a certain
488.
receptor on the tumor cells.
Yes, it is
That's why after
488
infusion, the
nanometers.
CAR T
Thank
cell
you.
go
Actually,
directly to the tumor cell
it
to
is
destroy it.
488
So this is
nanometers
the idea
because
behind the
why
CAR
is
T
it
cell
important?
therapy.
What if I told you that
So
the
this is the
mammalian
structure
cell that
of
you
the
are dealing with
genetically
is
engineered
around this
receptors.
size? Usually,
It is composed of
500
antigen
nanometers,
recognition
which
domain
makes
outside
it
the
kind
surface.
of
And there is
averagely
a
equal
hinge
to
region,
the
which is a
wavelength
spacer.
of the laser.
And there is a transmembrane domain
even
to fix
important?
the receptor
It
in
is
the
very,
membrane of the
very
T cell.
important. Now you will
And
know why.
finally, the
Let me tell you
intracytoplasmic
that the
part, which is the
relationship between the
intracytoplasmic T
size
cell
of your
signaling
cell
domain.
and the
So
wavelength
this
of the
genetically
laser is
engineered
going
receptor,
to
after genetically
identify
engineering
a
it,
lot of the
it is
parameters that you
embedded on
need
the
to
surface of the
identify
T cell,
inside the
multiplying
cells
the T
that you are
cell
going to
to
diagnose
millions
for.
of copies
The
and
collecting
reinfused
angle is
again
going
to
to
be
be
directed
important, and the
against
refractive
the
angle
specific
index is
cancer in
going
the
to
body.
be important.
Again,
Let me show
what
you a
about the
figure
clinical
which is
application
going
of the CAR
to
T cell in
say
different
what I'm saying in a
diagnosis
different
of
language, which is
solid
the
tumors
language of
and
figure.
leukemia lymphoma?
Now you see
This
that
is
the
an example
laser
of
is
a
intersecting with a cell.
paper published in
When this cell
2021
was
in Journal of
smaller
Immune Cancer
than the
Therapy
wavelength, this is the
regarding
wavelength,
using
the
of the
diameter
CAR T cell
of the
therapy
laser is its
targeting
wavelength.
CD33
When it's
directed
going to
for the acute
intersect
myeloid
with
leukemia.
the laser and
And
it
this
is
study
smaller in
demonstrated a
size, it's
preclinical
going to emit
optimization of
light
CD33
with
CAR T cell
lower
therapy in children
intensity
and adolescent young
than
adults
it
with
is
relapsed refractory
when
AML.
this cell it is going to be
Also
larger
using
or equal
CAR T cell
than
therapy
the
against
diameter
E-cell
of
ALL,
that laser.
but
Do
in this
you
study,
Can
which
you
is published in
imagine
Blood
that
in
this is the light
2022, it
intensity
is
of
not
the
only
small particle,
targeting
and
one
this is the light
receptor,
intensity
but
of the
it
large particle? Do you
it
think
is
they are
targeting two
equal?
receptors,
Do you think they are equal?
CD19 and CD22.
Which
So
is
this
more,
is as a to
the small
overcome
particle
a
or the
single
larger particle?
antigen
The
modulation.
larger
And as we
part.
mentioned before,
Definitely the
there is an
larger
escape
particle.
mechanism
Definitely
of
the
the
larger
tumor
particle.
cell
So
to
knowing
try
that, you will
to escape
understand
from
why it is
the immune system.
important that I
So
have
by
made you
sometimes
revise
by changing
the
the
nanometers
receptor on
of
the
the blue
surface.
laser you are
So
dealing
if I
with
make
according to
a
the
genetically
size
engineered
of your
receptor of the
cell
CAR
or
T
the
cell
mammalian cell, which is
targeting
actually
two
100,
receptors, not
which
only
is actually
one,
500
so we
nanometers
can
plus
overcome
minus equal
this single
the
antigen
wavelength of the
modulation.
blue laser. Let
So
me
this
show
result
you
showed
how
a
the
complete
angle,
response
the
rate
collecting
in
angle is
20% of
going
the
to
patient, which is
define
12
a
patients
very
out of 20.
important decision
Cytokine
about
release
the
syndrome, which is a
scattering of
major
light
side effect of
we
the CAR
are
T cell
going to
therapy,
deal with inside of
was
those cytometry.
recorded in only 50% of the
You can
patients.
see that when the
And
size
6
of
months,
the
12
of
months
the cell
relapse-free
was
survival
larger
was
than the
mentioned in
laser,
80%
the
and
highest intensity of light
100%
was at
in
an
this study.
angle of 180.
Also, we have an example of
forward
using CAR T-cell
scattering
therapy
angle.
against
What does it mean?
T-cell
When we
leukemia
use
or
the flow
lymphoma.
cytometry and we have the
So,
data,
as
we
we
have
see
something
here
which
in
is
this
called
figure,
forward
this is a
scatter and
PET
side scan.
scan of
Forward
the
scatter and
T-cell
side scan. What
lymphoma
is the forward and
before
what is the
starting
side?
treatment, and this
Actually,
is a
it
PET
is the
scan
collecting angle that you are
of
going to
the same
collect
patient after
the
using
scattered
CAR T-cell therapy
scattered
against
light
T-cell.
with. If you are going to
So it showed very good
the
response.
photodiode or the
That's why the
photomultiplier tube
CD5
on
CAR
an
T-cell
angle
therapy
of
are safe
180,
and can
this is the
induce
forward
clinical
scan.
responses
If you
in
are
heavily
going to
treated patients
situate it on
with
90
relapsed refractory
degrees, this is the
CD5
side scan.
positive
Why
T-cell
is this
leukemia
place
or
important?
lymphoma
Why is the
without
collecting
inducing
angle
complete
important?
T-cell
Due to
aplasia.
this figure you are looking at, there is a law
So
in
this
the
is
physics
using
called the
CAR
meat
T-cell
scattering
therapy
law.
in
It is
leukemia
total
and
physics,
lymphoma. What about
which
the CAR
says that
T-cell
if the
against
light,
the
if the
brain
incident
tumors?
light is
So
going
this
to
is
hit
an article published in
a large
2022
particle than the size of
demonstrating leukoregional delivery of the CAR T-cell therapy for cerebrospinal fluid to
the
treat the
laser beam,
metastatic
it is going
medulloblastoma
to
and
be
ependymoma.
scattered the
And
most
as we see
on
in
an
this
angle
picture,
of 180.
so the first
So this
pictures,
means
this is
that
a
if
day
you are
zero,
going to
which is a
situate an angle to
disease
collect
before
this
using the
light
CAR T-cell
on
therapy.
180,
After 1
it is
month, we
going
can
to be
find a very good
higher
response
in the
for
intensity
this
than
metastatic
situating it
medulloblastoma or
on 90
ependymoma.
degrees.
And at the
This is
end of the
important? Yes,
study,
it is.
we can only find two
Same
pictures
goes when
showed
it is
a
on an
recurrence,
equal size
but the
or
other
larger,
picture
it is
showed
going to be scattered
complete
behind
remission,
on
which is a very good and
180.
promising
What
result
if
of
this
using
particle that is
CAR
going to
T-cell
meet the
therapy
laser is going to
against
be
brain tumors?
very small in size, even less than 1/10 of the size
Neuroblastoma
of the
with CAR T-cell
diameter of the
therapy.
laser.
Neuroblastoma,
Now,
this
as
is
far
our
as the
challenges in the
isotropic
last
light scattering,
maybe
not
20,
the beam
30 years,
scattering
because
law, which is the
we are
Rayleigh
trying to
scattering law,
use
as you can
chemotherapy,
see in this third picture.
transplant,
And
either
here I
single
don't say
transplant or
from,
tandem
if you can
transplant,
see
immune
the ray
therapy like
the
monoclonal
mouse I'm moving
antibodies,
with, that the
anti-GD2,
rays are
and also
mostly
now we are trying to
equal
use
in
CAR T-cell
all
therapy
sides.
against
So it doesn't
neuroblastoma
matter if I'm
and
going to collect
targeting
the light on
different
90 degrees,
antigens.
180
So
degrees,
in this study,
90 degrees, or
which is the CAR
0
T-cell
degrees.
therapy targeting different antigens against
So 2
GB,
points I don't want
C2,
you
or
forget.
CD276.
Please remember,
So targeting these
180
multiple
degrees
tumor-associated
is the
antigens
highest intensity of light
against
scattered. If you are
these
going
specific
to deal with
receptors may
large
overcome
particles,
heterogeneous
like
expression
they
of a
are
target
equal
antigens
to the size
and
of the laser,
identified a
or they are
potent,
even more
clinically
than the
relevant
size of
CAR T-cell therapy against
the
neuroblastoma.
wavelength of your
But till
laser.
now, there is no
But this
definite
rule is not the
results
same if you are
to
dealing
conclude
with
the
very,
final
very small
the
particles,
final
which are
results
less
about
than 1
using a CAR
over
T-cell
10
therapy
of
for
the laser.
neuroblastoma as a standard of care.
Let me translate it into a much easier
Also, there is a
way.
CAR T-cell therapy
You can
targeting
see
HER2
that if you are
receptor
dealing
for
with
the
a small
advanced sarcoma,
particle,
including
and this
osteosarcoma,
particle is
rhabdomyosarcoma,
going to
Ewing
emit
sarcoma,
light,
and other
and this
types of
light is
sarcoma.
going to be
And this study, which was
translated
done
to
in Texas Children's
electricity, and this
Hospital, showed
electricity is going to be
a good
translated
result
to
that
a
encourage
sign
using of the
channel.
CAR T-cell
It's
therapy
going,
for a
this is the 0
chemo-refractory
point,
or
this is our
relapsed
0 point.
synovial
If it is
sarcoma.
a small particle, it is going to be assigned to a
So
channel
now
near
in
the
details,
0.
we talked about
The more the
checkpoint
particle
inhibitors
is
and its
going to
application either
enlarge,
for the
or the
solid
larger
tumors
the
or
particle you are
leukemia
dealing
lymphoma.
with, the
Also, we
distance, the
talk
more
about
distance it will
the
move
CAR T-cell
away from
therapy
the
and its
0. This
application
is why
for
we say
solid
that the
tumors,
forward
leukemia, and
scattering
lymphoma.
is actually
Now, the third type
paired
of
with
the
the
immune
size
therapy, which
of
is a
that
monoclonal antibodies.
particle you are dealing
So
with.
in a very simple way,
Let
the
me
monoclonal
remind you
antibodies
something, that
is a different
until
mechanism of the immune
this
therapy. They
moment,
are
I
trying
am not
to
talking about chloroquine. I
create
am only
a
talking
specific
about
proteins
the physical
in the lab.
appearance of
This
the cell.
protein,
What
like
is
a
the
Y shape,
size
has
and
two
what is the
arms, one
complexity
arm
of the
targeting
cell?
a specific
Now we know
receptor
for
on the
sure
tumor
what
cells,
is the
and the other
protein,
arm
the,
for
the
connecting
size
the
of the
T
cell
cells
that is
to
going to
target this cancer
contribute
cell.
to its place.
So this
It
arm,
is
if
going to be
targeting
assigned to
specific receptor on the tumor
forward
cells,
scatter. So what
maybe
about the side scan?
CD20,
The
CD22,
side scan
CD19, whatever. So there is
is
many
actually
different monoclonal antibodies
related
according
to
to
the
which
complexity
target
of the cytoplasm.
it
What
can
do
attach
you
to it.
translate the complexity
So
is?
if
Can we
our
say
monoclonal antibodies targeting
the
CD20, it
granules
is
inside
rituximab. So rituximab may be one of
How
the
do you
first
imagine the
monoclonal
granules
antibody which was
inside the cell?
approved
Is
in
it going to be
1997
less than
for
1
adult
over
and
10 of a
approved
nasal, or
officially
is
in
it going to
pediatric
be more
just
than 1
recently, a
over
few
10
years
of a
ago
nasal?
in
What is it
2021.
that you assume?
And
Is it
as you
going
see
to
in
be
this
very
graph,
small,
using
or
of
is it going to
rituximab
be
with
very large?
chemotherapy had a superior
The
event-free
granules
survival
inside
better than
anyone.
using
You can
chemotherapy
say it.
alone, and the other
There's
curve
no
using of
judgment rule here.
rituximab
You
with
can say,
chemotherapy has an
what
overall
do you think about
survival
the
better
granules
than
inside
the
the cell?
chemotherapy alone. So this is the
Is it
monoclonal
small?
antibodies
Does it
against
follow the
CD20,
main
which is
scattering
rituximab.
law that it's going
What about the
to
monoclonal
scatter
antibodies
the high
targeting
180?
CD33, which is GO, gemtuzumab
I will say that
ozogamicin? So
actually
it
the
was approved
granules
in
inside the cell is
2017 for adult
definitely
and pediatric for
smaller
more
than
than
the
2
cell,
years,
and
and
that's
recently
why
it was
they
approved
will
in
not follow
2022 for
the main
pediatric more than 1 month.
phenomenon, and
So this graph
they are
also
going
is
to
a little bit
scatter on
complicated
a
graph, but it shows
non-main
a very
pattern,
good
and
and
that's why
promising
we
results of
collect
using
them on
gemtuzumab
tiny
ozogamicin
This is what I
against
call the
the
side scattering.
CD33,
So now
although
you
it has
know
a certain
that
side
why the
effects
forward
like
scatter is
SOS or
actually
VOD, but
paired
a
with the
little bit
size
in the
of the
recent few
cell.
years
The smaller
after
the size,
modification of
the
the
nearer it
dose,
is to the 0
we
point,
are trying to
and the
avoid this side
larger the
effect.
size, the distant it is from the
Another
0
example
point.
of
And
monoclonal
what about
antibodies
the
targeting
side scatter?
CD30, which
It's going
is
to be related
brentuximab.
to
So it was
the
approved in
complexity and the
2011 for
granules
adult
inside
and
the cell, and
2022 for
usually it
pediatric.
is
And
collected
here,
on
this is a
90
graph of
degrees as it
event-free
does not
survival using
follow the new
brentuximab
pattern.
with
The
chemotherapy
third
has
way,
a
which is
better
going to affect
or
the
superior
power of the
event-free
light,
survival
which is going to be
better
scattered,
than the
is
standard
the
care.
refraction
And
index
also,
and the difference
this
between
is a
the
relapse rate.
component
So
of the
it has
cell
a lower
itself
relapse
and
rate of
the
using
sunlight
brentuximab with
surrounding it.
chemotherapy better than the standard
Now
care, which
we
has
are
a
coming
higher
actually to
relapse rate.
understand the flow cytometry as we are seeing
Monoclonal
the graph
antibodies
inside
against
the lab.
CD19,
What
which
you can
is
see here is a
blinatumomab.
forward
It
scatter
was
and a side
approved
scatter.
in 2014 for adult and
The nearer you are to the side
2018
scatter,
for
to
pediatric.
the zero
And
point,
also,
means that you are
the
smaller
blue
in
arm
size
of
and
using
you
blinatumomab
contain
has
no
a
complexity
better
inside
disease-free
inside the
survival
class,
than
so
the red
there's
arm.
no
And
granules to
the blue arm
scatter
here
the
has an
light.
overall
So
survival better than the red arm
here we
without
will find
using
the first
blinatumomab.
population, which is the debris area, and it is
What
assigned
about
for
monoclonal
the
antibodies
RBC,
against
the
solid
platelet, the
tumors? As we
apoptotic
mentioned,
cell,
solid
and
tumors,
then
the
you will
main
find
challenging in the
the
solid tumors is
lymphocytes and
neuroblastoma.
the basophils,
So this is
and you will see
dinutuximab, which
that
is anti-GD2.
the basophils actually contain
So this
granules, but
dinutuximab
it
was
has low
approved
side scatter
in
because the type of
2015,
granules
but
inside
at
the
the
basophils
beginning, it should be
are
combined
fluidic
with
in nature, and as
GM-CSF
because they
and
are fluidic
interleukin-2
in nature,
for
they
the
do
treatment
not
of the
reflect the light,
pediatric
and
patient
so
with
the
high-risk
instrument itself
neuroblastoma.
reads it
And
as
it showed
a
a good
granule.
response rate and
Then
event-free
comes a
survival of
larger
the immune
cell
therapy
that it
better
is
than the standard
moderate
chemotherapy.
in
And
its
this is event-free
granularity
survival and
and
overall
larger
survival.
in its size,
Also, the
and
immune
here
therapy
lies the
has a higher
monocyte. Coming
overall
above
survival rate
is the
better than
neutrophils,
the
and
standard
you will
therapy.
find that the
But the
neutrophils
main issue of
actually
dinutuximab
bind on a
with
long scale of the side scatter.
GM-CSF and
Due to
interleukin-2,
presence of many
it has
types
a
of
lot of
granules
toxicity.
inside the
That's why
neutrophils.
there
We
is
have the
another
primary
version of the
granules, the
dinutuximab,
secondary
which is
granules, the tertiary
dinutuximab
granules,
beta.
and not all the
So
cells are
it was
equal
approved
for their
by
granular
European
content.
Medicine
So you
Agency
have cells,
in
those have
2017,
very little
and
content
it
of
can be
granules,
used
and they
alone
will
without
have low side
GM-CSF
scatter or
and
moderate side
without
scatter. And you
interleukin-2.
will have more, so you
And
will
the
have more
results
side
of
scatter, and
this
more and more and more
dinutuximab
and more,
beta
as it is a
without
heterogeneous
GM-CSF
population
and without
according to
interleukin-2
the granular,
is very similar to the
the granules
dinutuximab
they
with the
contain
other
inside.
medications.
The
So
highest
we got the
scattering
same
of
results
them all
and we
is the
avoided
eosinophil
the side
due to
effects.
the
Now we have
refractile
another
nature of its
anti-GD2
granules. It is
other
the
than
highest,
dinutuximab or
most
dinutuximab beta, which
in
is
the side scatter,
naxitumab.
and usually
So this
it
is
is
another example of
sometimes
monoclonal
emergent with the
antibodies
neutrophil, and you
against
will have to use specific technique
GD2.
to separate them
So
from
what is the
each
difference
other.
between
So
naxitumab
this
and dinutuximab or
very simple
dinutuximab beta?
graph
So it is
the
a humanized
method of
version. It
diagnosis
has
of
a
all
tenfold
types
higher
of
affinity
leukemia
than
that we are
dinutuximab,
going to talk about
and it
this
was
session
FDA
and the
approved
session,
in
inshallah,
2020.
coming after
We can
tackling
use
the diagnosis of
GM-CSF with
leukemia.
it,
Please
either with
remember
pediatric or
that
or
these
adult
are the
pediatric
normal cells that you are going to find
high-risk
using the
neuroblastoma,
قوة كاتب science كاتب.
either for a minor
There are
response or a
no
stable
normal
disease
cells in this
to
graph.
standard
All of
chemotherapy,
those cells
induction
are
therapy.
normal. So when you find an abnormal
The final
population, and let me
example of
remind you once
monoclonal
again,
antibodies
abnormal
against
population,
ERPP2,
now
which is trastuzumab.
you can tackle
So
your
it
population
was
of
approved
interest.
in
So making the very
1998
long story short,
against
knowing the
HER2-positive breast
normal is
cancer.
your only way to
So in children
identify
who
the
don't have
abnormal.
breast
Please
cancer, but
remember
the same
this word
receptor,
when
which
you
is
are going
HER2,
to
maybe
diagnose
we
a
can
case
find
of
this receptor
leukemia, and
in
you are
many
looking for
tumors
blast
like
area in the
osteosarcoma.
blast,
But using
blast in the
monoclonal
blast area.
antibodies, trastuzumab,
Now we are
against
saying what we
HER2
have
receptor
been
in the
saying before,
osteosarcoma patient, it
assigning
didn't
the
show
forward
any
scatter and the right scatter. You can see
response.
the
So
neutrophil is
trastuzumab
going
didn't
to
significantly
lie
improve
on high side
survival
scatter
when
and
combined
achieves
with the
large forward
chemotherapy in
scatter
metastatic
because it
osteosarcoma.
is granular and it is large in size. While the
Finally,
lymphocyte has very low
bevacizumab,
scattering
which is
regarding the
monoclonal
forward scatter
antibodies
due to its
targeting
small size,
antivascular
and
endothelial
it
growth
is
factor.
low content
It
of
did not
granules.
show
This is why we
significant
see the
benefit in
lymphocytes
rhabdomyosarcoma,
lying here
osteosarcoma,
above
or
it,
high-grade
the
glioma,
monocytes, and
but
above
there is
them
an
is the
objective
neutrophil.
response
Do
observed
I,
in low-grade
is
glioma
everything okay
and relapsed
since we
refractory
are
high-risk neuroblastoma.
moving, as we
So
are moving now?
bevacizumab
Is
as
everything
monoclonal
okay?
antibodies
Is there
against
anything
antivascular endothelial
that
growth factor,
looks like
still
kind of
there is a
different to
question
you?
mark of using these monoclonal antibodies.
Okay.
Maybe
Now
there
we
is
have
a good
said that we
response
are
or
using
a
the
good
forward scatter
results
and the
for
side scatter, and
low-grade
this is not
glioma
the
or
case when you
refractory
are dealing
neuroblastoma,
inside the nephew
but
with
there
diagnosis of leukemia.
is no
I have to be
solid
honest with you. We don't
good
use the
results
forward
to
scatter,
use
side
it
scatter
as a standard of
anymore.
care.
Instead, we use what is called CD45.
So
What is
now we
CD45?
finished three types
What
of
it is?
immunotherapy:
It is a
checkpoint inhibitors,
pan-specific marker.
CAR T
It
cell,
has 6
monoclonal
isoforms. We are
antibodies.
not going
Now, what
deep
about the
into
treatment
the
vaccine, which
details
is
of
a very common
CD45, but what
question
I want
we
you
can
to
face
understand, the
from our
45
patients,
is
from the
actually
families,
expressed
from
on
other
all
members.
the leukocytes
The
with
common question is there a
different
specific
intensity. Let me show you the
vaccine I
difference
can
between
receive it
the
to
forward scatter
protect
side
me
scatter
from
and
against
the
any cancer?
CD45 side scatter.
The
Forward
clear
scatter is
answer,
related
no.
to the
But there
size,
is
yes, we said.
there
But
is a
in
trials
reality,
and
as
there is
you are working
two
inside the lab,
FDA-approved
the
vaccine can
populations are
protect
not
against
so
a specific type of
magnificently
cancer.
separated as I have been showing you
So this
in
is
in
the
the last
idea of
lab.
the treatment
Actually, they
vaccine.
are
We can
so
take a
much
specific protein
amalgamated
from the
that
body,
you
from the
cannot
tumor cells,
separate the
inject in the
leukocyte
body,
from the
stimulate the
debris,
immune
and you
system
cannot
to make
separate it sometimes
antibodies
from the
directed
monocyte
against
or
this
even the
specific
blast
protein.
when they
So
are
we
found,
can make
and
a
the
custom-made
neutrophils are
cancer
lying on
treatment
a
vaccine
white area,
or
and
universal
sometimes
cancer
even
treatment vaccine,
entangled
or
with
I
the
can use
DNA.
dendritic
Why is
cell
that? Because actually,
as a
when the
cancer
forward
treatment
scatter and
vaccine.
side scatters
And for
are
example,
used,
this
you are not
FDA-approved
identifying the population by its marker. You are
cytoleucine T,
identifying the
and
population by
also there
its
is an
size
oncolytic
and by
virus
its
therapy as a cancer treatment
and by
vaccine,
its
which is
complexity.
also
So
approved by
you know
FDA,
that
which is called
monocytes have
TVEC
more
vaccine.
granules than the lymphocytes,
What about the
and you know that they
custom-made
are larger in
cancer
size,
treatment
so
vaccine?
you know their
So
place is
the
going to
immune
be
system in
higher
this
side
type
scatter
of
and
vaccine
higher
is
forward scatter.
directed
What
against
if you
features
have a
that
monocyte
are
that
unique
it
to
is
a specific cancer?
low
So
granular
that's why it's called
or
custom-made.
agranular,
And what about
and
the
it has
universal
smaller
cancer
size?
treatment
Where
vaccine? The
is it
vaccine is
going to
made
be?
from a
It is
tumor-associated
going to
antigen
lie on the
that
area
are
of the
found on a
leukocyte,
cancer
vice
cell for
versa.
many people,
What if
and that
you
can
have
be used
reactive
as an
leukocytes
immune
and they have
response
a
in
lot of
any patient
granules
who has a
and
cancer
they
that
have
produce the
large
same
size? Where
antigen?
are you going to
So this
express
is a
them? They
custom-made
are
and
going
the
to
universal
lie in
cancer
the
treatment vaccine.
monocyte area.
So what
So the
about
forward
this
scatter side
specific
scatter
type
did
of
not
cancer
tell you
vaccine,
that this is
which is
a
approved
leukocyte,
in
that this is a
FDA approved
monocyte.
in
The forward
2010?
scatter side scatter
So in
told you
this
that
type of cancer
I
vaccine, we
have
are using the
represented a cell
dendritic cell.
which is a
So that's why
smaller
it was
size
dendritic cell
and it
vaccine
is
that stimulate the immune
agranular.
system
So
to
you
respond
assume that it is
to a
going to be
specific
a
antigen.
lymphocyte. What if you
So we
need
can use
to
this
identify for
vaccine
sure
as
that
an
you
intravenous
are actually
infusion
gating on
to
what you need to
treat
gate
the
on?
metastatic
Now you
cancer
will have
prostate,
to
which
use
is
the
not
antigenic
responding to the
structure
hormonal
and the
therapy.
monoclonal
So it was
antibodies
used
that
as
we
a
have been
second or
talking
salvage
about
therapy
in
for
the
the
very first
metastatic
beginning
cancer
of this lecture.
prostate as an
So in
IV
your
injection.
consideration, please, that if you are
What
going
is
to
the other
use
type of the
CD45,
cancer
a
of
bit
the
of
treatment
this
vaccine against cancer?
advantage you are
So
going to
this
take, because
type
this
is oncolytic virus therapy, which is called
TVEC
TVEC vaccine. It was approved as oncolytic virus therapy from FDA. That it based on herpes simplex virus type 1. it was
than both
injected
of them,
directly into the
while the
tumor in case of
eosinophils
skin
expresses
melanoma that
45,
cannot be excised
even more than
surgically.
the neutrophils, so you
So
will find a way to separate them.
the
But
idea
this is
of the
not
treatment
the only
vaccine,
way. There
it is
are
not
other methods being
general
considered.
idea.
You
There
will
is no
find that the
specific
degree
vaccine I
area
can
is now
receive it to protect myself against the cancer,
separated
but there is a
from
trial
the
of
lymphocyte, the
creating a
lymphocyte
specific
area.
vaccine.
And you will have to see
Two of
the
them are
abnormal
actually FDA
population,
approved.
which
One
lie in what
is
we
using
call
the dendritic cells,
area,
which
this
can
is
be
this
used
viral
intravenous
area we call
infusion
the
against
window area. This is
metastatic
the
cancer
blast
prostate
area.
not
Now you
responding
can
to the hormonal
identify
therapy.
an
And the second is
abnormal
oncolytic virus
population
therapy
in front of
based
your
on the
eye,
herpes
so that
simplex
you can
virus
examine more and
injected
more about it.
directly
And when you are
into
dealing
the
with
skin
acute
melanoma
leukemia, the
cannot be
situation
excised surgically.
is clearer
So this is
on
the
the
main
forward scatter, side
4
scatter, or the
types of the immune
45
therapy.
side scatter.
The
because
last
you
item of
see
the
an
immune therapy,
abnormal
it is not a
population. When
specific
you are
immune
dealing with
therapy,
non-Hodgkin lymphoma,
but
actually
it is
you
a
are
certain
dealing
medications
with a population that lies
that has
inside the
an
mature
extra
lymphocytic
action
area. And
which
this
is
is why
enhancing the immune
I have
system.
been telling you
So
since the start of
if
this
this
lecture,
medication
please
enhances the immune
know the
system
normal so
against the
that
cancer
you
therapy,
can know
that's why
the
this
abnormal.
group of medications called
Now,
immune
saying that,
system
we have
modulator.
worked through
So
um,
this immune system modulator enhances the body immune response
identification
against
of
cancer.
the
The
cells
effect
inside
can
the
be
forward
specific
scatter,
or
side scatter,
specifically or
but we did
generally
not
on the immune
address
system.
the fluorochromes
So
or the
an example
monoclonal
of the immune
antibodies
system
that we
modulator
have
is
conjugated
cytokines,
with a specific
BCG,
fluorochrome
and
and
immune
attached
modulatory
it to a
drugs.
specific antigen.
So what about the
them?
cytokines? We have two
Now,
examples of
when you
cytokines,
know by the
interferons
forward
and
scatter, side
interleukins.
scatter, or the
Interferon
CD45
alpha
side
can
scatter,
enhance
the
the natural
population of
killer cell
interest
and
that you
dendritic
are
cells.
interested
Also,
in,
it
now
slows
you can
down the
see
growth
the
of the cancer
antigenic
cell and
structure you are
promote
dealing
the
with.
apoptosis
Let's
or
take for
promote the death.
instance the plot
Also,
that
the
I am
interleukin,
dealing
like
with
interleukin
here.
2,
I have the blue
it
area
is
in the area
a
of
growth
the
cell
T.
factor
The
that
lymphocyte
boosts killer T
is the
cell
red
and
area,
natural
the
killer cell.
monocyte is the
Also,
green
it
one,
helps
and the
B cell to
neutrophils
produce a certain
is the
substance
violet
that
area.
can target
If I
cell.
gated
So
on the
these cytokines
lymphocyte and
have
I gave
a general
instrument and order to
enhancing effect
identify
on the immune system.
whether
That's why they
this
are called
area
immune
has
system
a population
modulator.
which is positive
Another
for
example of the immune system
CD3
modulator, which is a
or
BCG.
CD4,
I think all
this
of
is
us
what we
know
call a
many
quadrant
data
block.
regarding the
What,
BCG.
what do we
So the
mean by a
BCG
quadrant
itself,
block?
it is a
I
vaccine,
have usually
but it is
one
not again
specific
a vaccine
antigenic
against cancer cell. It is a
antibody
vaccine against
fluorochrome to be
tuberculosis.
analyzed on the
And this
x-axis
vaccine
and
contains
another
weakened
fluorochrome to
version
be
of the
analyzed
bacteria called
on the
Mycobacterium
y-axis.
bovis.
Taking
So
it the
this is the
simplest
primary
form
action of
ever,
the BVC.
we
So
will
the
say
BVC
that
has a
this
primary
quadrant
action,
is
which
going
is
to contain the negative
vaccination
population.
against
This
T
quadrant is
tuberculosis.
going to
But it has
contain
a
the
secondary
population
action or
positive
extra action.
to the
We
fluorochrome
found that the
is in
BCG
the
vaccine
x-axis,
enhances the
while
immune therapy,
this
the immune system
quadrant,
against
the
the cancer
positive
cell.
population
That's
is the
why
y-axis, and
it was
this upper
considered
right
as
quadrant is
one
going
of
to
the immune
express
system
the
modulator. So the
population
primary action of the BCG
expressing
vaccine is tuberculosis
both
vaccine,
antigenic
but an extra
responses.
action is
So,
enhancing
for
the immune
instance,
system
I'm dealing with
against the cancer
CD3
cell.
in here
So how
and
can we use a
CD4
BCG
on
vaccine
the
as an immune system
y-axis.
modulator?
Do you
We can
expect
use it
this
by
population to
inject
be
the BCG
positive
directly
or
through a
negative for
catheter
both
into the bladder
markers, CD3
in
and
case of cancer
CD4?
bladder.
You tell me on the
So
chat.
what is the effect of using BCG vaccine as an immune
You
system
tell me on the
modulator in
chat.
cancer bladder after injecting directly through a
Do you
catheter?
expect this
It
to
can
be
delay the
positive or
growth
negative for the
and delay the spread of the cancer bladder
it is
into a
negative,
deeper
definitely.
layer. So the
But
BCG
what
vaccine
about this
has
one?
an extra action
Is
other
it
than the
positive
primary action
for
against
CD3
tuberculosis.
and
It has
CD4
an
or
extra action
CD3
if it
only?
is injected directly
This
into
one,
the
I mean
bladder
the lower
as a cancer,
right,
which
the
is a
lower
slow
right quadrant, this
or
one.
slow growth of the cancer and prevent
What do you expect?
deepening of the cancer
Is it
bladder into the
positive for
deeper
both, or is it
layers.
positive for 4, or is it positive
This is
for
another
3?
example of the immune system modulator. The last example of the immune system modulator is a certain medications like thalidomide, like lenalidomide, pomalidomide,
Yes,
or
only
mode.
This is right.
So all
And
of them
so you can
are
understand
angiogenesis
that
inhibitor for the
this
cancer cells,
quadrant
and the
block
last
is
one
actually
enhances the cell
saying
to
it
release the
all
cytokines.
in relation
So all
to
these medications
that
has a
the
primary
interpretive
action,
data
and beside the
that you
primary
have
action,
been
it has
using the
another
antibody,
secondary action that
which
it
is
will inhibit
actually
the angiogenesis.
related
That's
to
why it enhances the immune
abdominal,
system
and
to
you
fight
have
against the cancer
examined
therapy.
the light,
That's why
which
they
is
called immune system
which
modulator.
is
So this is the last
emitted
example
from this
of the immune system
protocol
modulator,
after it hit
immune
the
system therapy. Now
instrument laser, and after it is
we finished the
translated by the
5 main sections of the immune therapy.
into
The first part
electricity,
is
and
checkpoint
this
inhibitors.
electricity
The
is
second
to
part
be
is
assigned to these
CAR T-cell
dots that
therapy.
you are
The third
seeing
part,
inside
monoclonal
your
antibodies.
So
The fourth part is
saying that,
treatment
the
vaccine.
whole
The
idea
fifth
about
part
the
is
process
immune
we are
system
talking about,
modulator.
the flow
All of
cytometry
them
is
under the
actually
umbrella of the
scattering
immune
light,
therapy.
collecting the scattered
So
light,
this is the
defining
last
the
slide,
scattered light,
which is, I think,
translating the
we
scattered
can talk
light
about
into
these
electricity,
items
assigning this
many hours.
electricity to a
But in brief,
specific
there is
space on the
different
dot
way
plot
to
of the
improve
quadrant
the
plot to
efficacy
see
of the
whether
immune
it is
therapy.
negative or
Maybe
positive.
we
Is it
can
easy or is
overcome
it
the
hard?
resistance.
This is the
Maybe
simplest
we
form.
need a better
As we are
assessment
moving now, is
of
there any kind
this
of
immune
problem that you are
therapy.
dealing
We
with?
need to overcome the mechanism by which the
I hope
cancer
not,
cell
inshallah. I
suppresses the
hope
immune
not.
response. And finally, which is a
So
very obstacle of
actually,
using
the way
immune
you
therapy
are going
is
to
the side
interpret
effect.
this
If
data
we
is
minimize
going to
the side
be
effect as
through
much as we
two
can,
ways. Either
this
you
is
are
a very
going
good
to
challenge
examine
to
a
improve
single
the efficacy
color
of the
alone,
immune therapy.
and the Y
So now I'm
the
done.
Y-axis
Thank you
is
so
going
much.
to be the
And
count
thank
or
you
the
for the
number of
organizer.
cells,
And this
and
is
then
our
you will
National
see
Cancer
that
Institute
you
in
will have a
Cairo,
positive
the old
population
campus
and
and
a
the new
negative
campus.
population. But
Thank
you
you, and
don't
I'm ready
have
for
here
any
to
question for you.
examine
Thank you.
co-expression. Or you are going
Thank
to
you,
use
Professor
the
Yasser, for
quadrant
this
plot
informative
to
lecture
see
that
what
helped
is
us to
positive on the
understand more about
x-axis
the
and
different
what
types of
is
immunotherapy.
positive only for
Please,
the
if you have any
y-axis
question,
monoclonal,
raise
and
your
what is
hand or
going to
write
be
it in the
positive
chat box.
for both lying in the upper right graph. So defining your population of interest is actually everything in relation to this. Taking into your consideration what is the population of interest that you are dealing with, this part we are going to address specifically when we are going to talk about the leukemia diagnosis. So I am going to pass through it in a very quick portion, but I would like to tell you that you are going to use these kind of interpretations we are talking about to use the flow cytometry in the clinical setting. First, you identify population of interest according to the signature of the CD. And by the second session, please, I want you all to revise the table of the signature CDs of each cell so that this will make things easy when we pass through the cases of leukemia and the cases of lymphocytic subpopulations to know things in a much easier way. And then we will diagnose the protocols of leukemia and minimal residual disease, or we can extract the data on the defined population away from the leukemia diagnosis. What are the CD markers in unit phenotyping? Please revise this table for the second session. Now you know by heart what is the difference between forward scatter, side scatter, and CD45 side scatter. We will tackle very simply the diagnosis of leukemia in 4 questions. So we can heat things up for the second session. To diagnose the leukemia, you have first to understand, do you have an abnormal population inside your graph? How you are going to see that if you don't know the normal? What antigens are the blast expressing? What is the lineage of this blast, and how you can assign each blast to each specific lineage? And thus, this lineage carries apparency, and what is the importance of this apparency in relation to the flow cytometry? In order to make things in rule for the second session, inshallah, just please remember that the abnormal population we are going to talk about in the second session usually lies in what we call the window area. That is a dim CD45 expressing population. You see, lymphocytes is the dark blue population, the monocytes are the violet, and the green is the neutrophils. What is the red population? Is this red population normal? Did you see it before? Never. This is an abnormal population. This is the blast window area. Does all the leukemic blasts lie in this area? No, actually not. According to the type of blast, you are going to identify you are going to find it lying in different areas. Myeloblasts are usually dim to moderate 45. Monoblasts are usually high and bright 45. ABL, acute lymphocytic leukemia, lies in the neutrophilic area. The variant acute pro-lymphocytic leukemia lies in a low side scattered than the neutrophilic area. Looks like a bit the monocytic area. It's not specifically the monocyte, but very similar. The lymphoblast, whether we also hear about the acute lymphoblastic leukemia, is either bimodal. What do I mean by bimodal? Some of the blasts are even, part of it lies in the negative 45, while other blasts lie in the dim 45. Some BALL are totally negative CD45. TALL has a moderate expression of CD45 with low side scattering. How can I identify the blast? First, you will have to identify the immaturity markers of those blasts. Please remember 4 markers. We are going to use them a lot in the second session. CD34, CD38, TDT, and CD117. And please remember that when I usually express the immaturity markers, I lack the maturity markers. What are the maturity markers? CD11B, CD15, CD16, and CD65. These are the immaturity markers I have been asking you to revise, inshallah, for the next session. Are all the blasts have to express CD34? Definitely no. Some blasts are even known as CD34 negative blasts, like the pre-BALL before the signs of maturation. T acute lymphoblastic leukemia blast, they do not express CD34. Erythroid blast, monoblast, many times not expressing negative blast, and acute myeloid leukemia with nucleotosmine mutation usually are not expressing CD34. I will leave the panels of the leukemia to the second session and how to assign each one to each specific antigen, to each specific lineage according to each antigenic structure. But please remember that the site of the presence of cell antigen is not always the surface. Sometimes you have cytoplasmic markers. If you are going to examine cytoplasmic markers, you will have to permeabilize the surface of the cell to reach the cytoplasm. Like in case of cytoplasmic CD3 myeloperoxidase enzyme or the mu chain of the B cells. Sometimes it is even nuclear, like the TDT. So knowing where you are going to find the antigenic structure inside the flow cytometry lab is fundamental for you to see if it is positive or negative. Do not look for it in the wrong place, and then you are going to report it as not found while it was actually found, but you did not know. One of the important things that I want you to know from today, inshallah, is the apparency. What is the apparency? Sometimes the cells can be identified by several pan-lineage antigens, but they are co-expressing antigens. Those are related to another lineage, like in case some of The B lymphoblast you are going to know is going to express CD19, cytoplasmic CD22, CD79. I see that it is expressing a myeloid antigen like CD65. This is apparency. So apparency is expressing an antigen from a different lineage. Sometimes expressing an antigen in different mode of expression. Usually I express it high. When I got the malignancy, now I express it on low expression. Or I was expressing it low. Now when I got the malignancy, I'm expressing it on a high expression. So why is it important to know those things? What makes this thing important to know if you are going to tackle the flow cytometry? This is going to be very, very important when we are going to talk about the minimal residual disease. Please remember that when you are talking about the minimal residual disease, as Dr. Sally has manifested in her wonderful lecture in the molecular, when you are seeing minimal residual disease with the molecular techniques, you are actually looking for the expression of abnormal protein by the cell. With the flow cytometry, you are going to tackle minimal residual disease by searching for abnormal cells. How would you define those abnormal cells when there is apparency? This is going to make things much, much, much easier for you in case you want to diagnose acute leukemia, and then you are going to follow up by the flow cytometry. Is the flow cytometry the most sensitive or the molecular most sensitive? Well, unfortunately, I have to say that still the molecular has the upper hand, as the sensitivity of the flow cytometry is 10 to the power minus 4, while the sensitivity of the molecular is ranging up to 10 to the power minus 6. As you can see in here, the graph is showing you the differences in follow-up of the flow cytometry between if you are going to address it by the normal morphological techniques, which was used in the late era by counting 100 or even 1,000 cell, and then you are going to see what is going, how many blasts you are going to identify by morphology. The flow cytometry is even much, much more sensitive. You can identify an abnormal cell with an 10 to the power minus 4 sensitivity, but still the molecular is actually taking the upper hand, I have to say. Sometimes you need to use the flow cytometry to address the immune cells which are actually found in the microenvironment inside the cell. In order to know those types of cells, you will have to identify what is the specific marker of each cell, especially like one of the very most important cell which was found in the immune therapy now is the T cell and the T regulatory. When you are looking for the T regulatory, you have to identify the T regulatory by its characteristic. Don't look for T regulatory cells. Those are positive for FOXP3, CD25, and CD4. No, actually, you are looking for high CD25 expressing CD4. As you can see in here, that only the high CD25 are expressing the transcriptional factor of the T regulatory, that is FOXP3, the highest intensity of them all, while the intermediate, the low, and the negative are not. Sometimes you need to tackle the detection of the cells by absolute count. You have to know the number of cells found in the liters, and the flow cytometry can help you so much in this, and definitely people in the National Cancer Institute using these techniques daily for stem cell counting. Sometimes you need to see the antigenic density of the cell, as we have said that according to the saturation of the antigenic density, the amount of the antibodies, those are going to be attached to these antigens, are going to emit light. If you only have 2 antigens, this light is going to have low intensity, while this, if you have more antigenic structure, this light is going to have more and more intensity. This is why you can define the expression, the intensity of light. Either you have negative expression or dim expression or moderate expression or high expression according to their mode of expression. Then you can use the flow cytometry for the detection of the microparticles and the exosome. And this area is now very, very wide, as they are saying that the microparticles are the exosomes are responsible for the communication of the malignant cells with the microenvironment. And wonderful, wonderful papers you can find in this. And it has actually a different maneuver and different technique than that you are tackling in the normal leukemic diagnosis setting. Sometimes you use the flow cytometry to see the stimulation of a cell and its response to a specific stimulant. And if you are going to use the flow cytometry in this era, please remember that the only control you are going to use is going to be the unstimulated cell in order to find out whether there is stimulation or not. Always, always compare with the first, second unstimulated cells you are going to use. Please remember that if you are going to tackle stimulation and you are looking for something like nuclear factor kappa B or things like that, you are dealing with internuclear structure. So do not report a surface structure. You may need even a harsh techniques in permeabilization, like some people are using the alcohol, which is very, very harsh. And also you will have to use the Burkendine to allow the accumulation of the target protein inside the cell and to decrease its spillover from the cell to the outside, and you can gate in it while you are gating. Do we have some kind of limitations in the flow cytometry? Yes, we do. Sometimes the number of blasts you are looking for is underestimated by the flow cytometry, and you have to be very honest with yourself. Yes, you do have many, many limitations. Sometimes you have fibrosis, which will lead to low bone marrow aspirate, a number of cells of the blast. Sometimes you have uneven distribution due to patchy form of the leukemia. Sometimes you have abnormal phenotype of blast. Those do not express the immaturity markers, and you have to know their immaturity by different ways, which will depend on the experience of the people who are actually examining the blast. Flow cytometry analysis relies on the detection of a membrane and most of surface or cytoplasmic structure. So the integrity of the membrane and the cell being alive and using a fresh sample is actually one of the challenges. The most important thing is using a cell which has been withdrawn within 2 hours from the patient. This is not usually applicable. Decrease the viability of the sample will lead to false results. Sometimes the number of blasts can be even more higher detected by the flow cytometry than it is on the real life due to abnormal trafficking of the blast inside the bone marrow, also due to fibrosis. So when you are dealing with a case of fibrosis, you will have to remember that you can either overestimate or underestimate. One of the most important challenges that, as I said, that you have to deal with an intact membrane of the cell. Please, please, please avoid using a dead cell. How can I use a dead cell? How can I use 100% living cell? You can either use a live dead cell kit or palladium iodide, as it is going only to be taken by the dead cells, and then you are going to exclude the cells. Those are positive for the palladium iodide, and then you can be sure that you are getting only on the normal living cells. These are the references that I have used today, and the blogs that I have been using are mostly coming from these wonderful 3 books, and I do so much invite you
Hello,
to read
everybody.
them,
Good
especially
evening.
practice flow cytometry in
Do you hear me?
This book is wonderful. The protocols
Yes,
of
Dr.
the
We
type
are hearing
of
you.
maneuvers I have been
Okay,
tackling
so
is
can I
actually
start now or
inside the
wait
flow
for another few
cytometry
minutes?
I
put
think
it
we
for
can
you.
wait just a
It
couple
is
of
found
minutes
in the
because
reports.
the
By this,
numbers
I
are
reach
increasing.
the end of
Okay.
my lecture. I hope it was
So we are
not
ready. If
so
you are
much
okay,
long
just
on
let me
you.
know and we'll
I
start,
know
inshallah.
that it is
Okay.
a very, very, I don't know how to say, a fat lecture, but it has to be said like this in order to get into the diagnosis of acute leukemia and the minimal residual disease, inshallah, the next time. So I'm open for any questions. If you want something, I'm more than happy to run with you, unless I know that I'm kind of late. So pardon me once again for the committee. I don't know how to say thank you because it was an honor actually being with you. Because I wanted everyone to know those basic information could be, yes, kind of fact, as they are saying, but they are fundamental to understand what's coming for the diagnosis of leukemia and the minimal residual disease. Thank you so much.
Thank you. Thank you, Professor Reham, for this very informative lecture. It really helped us delve into the fundamental principles of flow cytometry. You really just provided a strong foundation for us to understand more advanced concepts and applications of flow cytometry in the future. So
Okay,
thank you so
hello
much for this
everyone.
lecture.
Thank you for joining
So dear
us today.
attendees, please raise your hand
Welcome
if
to
you
the
have
South
questions to
Africa
ask, or you can
Education
write
and
them in
Training
the chat box
Committee
if you
program.
prefer.
It's our fifth session of the basics module. Please all don't forget to fill the registration form. Every lecture, it will be sent in the chat box as 8 of your attendance is required to get your
If
certificate.
you want to ask questions,
Lectures
you
are
can
held
just
every
raise
Wednesday,
your
so the
hand
next
and
one will
open
be
your
on the 12th
mic.
of February.
And if you
Please don't
prefer to
hesitate
write it
to
in the
write
chat
your
box,
questions in the chat box
we
or
will
raise
read
your
the
hands
question
if you
for
want
you.
to ask. Our
And
lecture
Professor
today is
Reham
about the
will be
specific
glad to
anti-cancer
answer.
immunotherapies and monoclonal
Maybe you have
antibodies.
any questions,
It will be
inshallah.
presented by Professor Dr. Yasser Al-Borai. Dr. Yasser is a professor of pediatric oncology and stem
They're all thanking
cell
you.
transplant
It was really interesting.
at National
And,
Cancer Institute Egypt and Prince Sultan Medical City, Saudi Arabia. Dr. Yasser, if you are ready, we can start. Dr. Yasser, can you hear me?
Yeah, I'm hearing you. So hello everybody. Thank you so much for
seems
this
like they don't
educational
have any
program for the
questions.
South Africa.
It
In the
was
next few
perfectly
minutes,
clear.
we'll talk about specific
you.
anti-cancer
I think
immune therapy and monoclonal antibodies.
into collecting.
Okay, so first of all, we need to know
Okay,
how can
so
we
thank
do
you again, Professor
fight
Reham.
cancer cell. So we have
And
many
thank you
modalities
all
to
for
treat the
joining
cancer
us
cell.
this afternoon, this
Maybe with
evening.
surgery,
Just a
maybe
gentle
with
reminder to
chemotherapy,
register with the form. It was
maybe
already
with
sent in the chat
radiotherapy,
box to be eligible
hormonal
for the
therapy,
certificates. And
transplant
stay
therapy,
tuned for next
target
lecture. It
therapy,
will be next
hyperthermia,
Wednesday, February
and
5th.
finally, immune therapy.
And if you want to join the
So,
Cytometry Africa
what
WhatsApp
is the
group,
immune
you
therapy?
can send a message
So,
in the
as you
chat
know,
box with your phone
after
number
many
so we
years
can
of
add
using
you.
the traditional
Have a
chemotherapy
nice
with a lot
evening
of
and see you
toxicities, a
next
lot of side
week.
effects,
Thank you and goodbye.
a lot of morbidities
Thank you so
due to
much.
the toxicity of the chemotherapy, it was a time to think about how can we use the natural immune system to fight with us against cancer away from the traditional chemotherapy. So the immune therapy is a biological therapy that help our immune system to fight the cancer. So this is a fight between the immune system and the cancer cell. The immune system tries to hit the cancer cell, and on the opposite side, as a defense mechanism, we can find the cancer cell try to find different defense mechanism to escape from this immune system. Maybe by genetic changes that make the cancer cell less visible to the immune system. Maybe by creating a specific proteins on the surface to turn off the immune system, or maybe by changing the surrounding media around the cancer cell to escape the mechanism of the immune system. So the immune therapy, it is not only one type of therapy. The immune therapy, simply we can define the immune therapy into major 5 different types. So checkpoint inhibitors is a type of the immune therapy. T-cell transfer therapy or CAR T-cell is another type of the immune therapy. Monoclonal antibodies is another type of the immune therapy. There is a specific vaccine targeting the cancer cell, which is called the treatment vaccine, is another type of the immune therapy. And finally, there is another medications. This medication has a primary action, which is totally away from our target, but also it has a secondary action, which is enhancing the effect of the immune therapy against the cancer cell. That's why it's called immune system modulator. So in the next couple of slides, we'll talk specifically about each type of the immune therapy in couple of slides. So as we mentioned, we have major 5 different types of the immune therapy. Now we'll talk about the immune checkpoint inhibitors. So in a very simple way, what is the checkpoint inhibitors? Normally, the checkpoint like a brake of the car. So normally the car is the immune system going very fast to attack the cancer cell. And as a defense mechanism, the cancer cell has an arm. This arm can touch the brake of the car to make it slow down. So this is the mechanism, the defense mechanism of the cancer cell against the immune system. So this is the checkpoint. So the checkpoint like the brake of the car. So the car or the immune system had a brake, and the tumor cells had the arm that touch the brake, make the immune system or make the car very slow. That's why the cancer cell escape from the immune system. So what about if I inhibit it? If I inhibit this brake, I prevent the arm of the tumor cells to reach the brake of the car. So if there is no brake, there is no slow down of the car. So the immune system or the car will go very fast to hit the cancer cell. So this is the idea of the checkpoint inhibitors. So we are inhibiting the brake of the car or the brake of the immune system. If there is no brake, the car or the immune system will go very fast without any slowdown and will hit the tumor cells. So here we can find the tumor cells, and this is the arm of the tumor cells. And this is the immune cells, which is a T cell, and this is the brake of the tumor of the T cells. So if the arm of the tumor cell